FaceTime session with Dr. Gerry Samson and his guest today, Dr. Lee Boyd. I am Allison Farrell, Director of Marketing for Fireside. So we are recording this session where people are kind of entering in from the waiting room now. But if you've got to hop off at any point, know that we will have the recording and we'll post it on YouTube as well. But real quick, I'm going to turn it over to our CEO, Bart Yancey, who'll share a few thoughts about Fireside. So Bart, take it
Yeah,
away.
great. Thank you, Allison. Thank you, Dr. Boyd, Dr. Samson. We're looking forward to this session and appreciate everyone joining us. I'm going to spend just a minute here and tell you a little bit about Fireside and why we're so excited about the organization and the growth that we're seeing. So I'll start with, as all of you probably have felt, we are in an era of dental consolidation. This consolidation is a trend that we've seen take place with physician offices over the last several years as well. And so it's not new to dental. It's not a trend that we've seen just in dental, but a trend that we're seeing all across healthcare. And we're helping our members at Fireside stay independent and thrive. Group purchasing is a concept that we utilize at Fireside for our membership. And what's interesting is that group purchasing is not a new concept in healthcare. In fact, 97% of hospitals utilize group purchasing. Medical practices, 72% are utilizing group purchasing, but it's still a fairly new trend within dental practices. And so it's an excellent way to, as a standalone independent pediatric practice, to come together with an organization and receive the benefits of being a part of a group. So that's savings in different areas of your business. One thing that we have learned quickly through our membership at Fireside, we're now up to having members in 15 states. We've got almost 100 pediatric dentists that are members of Fireside. So we're a very new organization with a new concept that we're bringing to the market. But we understand that as private practice pediatric dentists, you don't have a lot of time on your hands to deal with the growing overhead, the shrinking profit margins. And so we understand that that's a limitation as far as having the time to actually deal with that. So we come alongside our members and help you address those areas of your practice through what we call quick wins. Quick wins is a process where we're utilizing our group purchasing power and delivering significant savings in clinical supplies and equipment. Every one of our members receives a subscription to our purchasing platform, which brings transparency and streamlines that purchasing process around clinical supplies. Payment processing is another area where we're adding additional savings for our members. We also have a community where we're bringing educational resources like the live stream that we're on today. So we do several of these where we bring in industry experts. Everything is laser focused on private practice pediatric dentist, all the way from our savings and our partnerships to the content that we're delivering. And then finally, we're about to launch a digital content and advertising service for our members who are interested in getting some passive income for their practice. So we're delivering 20% plus savings for our members. Again, these are quick wins, so they're very easy to implement and start to see the savings. So we're really implementing these with minimal staff or involvement. We have a dedicated member services team, and then we have a risk-free guarantee. That means that at the end of a year, if you haven't saved the equivalent to your membership, we'll make you whole. So there's no risk in joining Fireside, and that's how confident we are in the savings that we're delivering for our members. So joining Fireside is really easy. We like to do an intro call with all of our prospective members. And so that's a 30-minute call where we'll give you more of the details about Fireside, how easy it is to realize these savings, and how you can have a partner that can support you. You then sign a member agreement, and we implement the quick wins. And the quick wins is easily implemented within the first 30 days of your membership. Our monthly membership is $400 a month if you pay annually, and then $475 month to month. So we would love to have you schedule a call with us. We'll follow up with an email so that you can easily schedule that call. But again, thank you for attending, and go get them, Lee.
All right.
And while he's switching the slides over, just one reminder, I did not mention this at the beginning, but if you've got any questions for Dr. Boyd or Dr. Samson throughout the session, you can use the Q&A box and we'll pop in and Dr. Boyd will answer the question. So, and again, just to thank Dr. Samson for putting this series together and helping us lead this content. But I will turn it over to you guys.
Unmute, Jerry.
Thank you. I knew that. I think one of the fascinating things about Lee Boyd, he's taken over. He's like my keeper. One of the fascinating things about Fireside that got my attention, and I think gets everyone's attention that's a pediatric dentist, is the exclusivity that it's for pediatric dentists only. And we know that plenty of other organizations do such things. But as far as I'm aware, Fireside's the first one that's really targeting pediatric dentists in private practice. I will mention to you that I think many of you know that I'm the Director of Education for Specialty Dental Brands, which is a large DSO, pediatric dentistry, orthodontics, and oral surgery only. It's a $2 billion outfit. And everybody in the DSO space, all the DSOs, are pretty much right now in, I'm going to call it carbon freeze, because of interest rates and nervous about what's happening with the economy and what's happening in the world. But the advice that I can tell you that happens at the highest level of these DSOs is, if you're a pediatric dentist, an orthodontist, or an oral surgeon, your best course of action right now is to keep your practice growing. Because whether you bring in an associate, a partner, or you investigate moving in with a DSO in some way, shape, or form, nobody is going to give advice to get with a business that is flatlined or is slipping off. You really should be aware of that. I certainly was not until this has been pointed out to me. Even if you're selling to a private person or you're bringing in a new partner, their financial advisor is going to tell them if this thing is flat or slipping off, it doesn't matter what the potential is. It doesn't matter, oh, well, if we open another day a week. Well, you haven't. Well, we could bring out another hygienist. Well, you haven't. So what Fireside is actually targeting is continuing for you to have increased value of your business. Now, if you're like me and you didn't realize your microphone was muted, you should stay on mute so that we can avoid background noise during the presentation. And Lee Boyd and Lee, how long have you been involved in nathos?
22 years, I think.
22 years. And it's kind of an interesting thing. I'll leave it to Lee to explain this to you by and large. But Lee started applying things that he had learned in nathos and orthodontics to clear aligners, Invisalign specifically. And because there are things that I chose, for those of you that aren't aware of this, I chose to not use Herbst appliances. I'd figured out ways around that. I chose not to use mini screws or temporary anchorage devices in orthodontic cases. I'd already figured out ways around that because they hadn't been invented. And when Invisalign came out, same thing. I thought, nah, I'm not interested in doing that, and completely underestimated, as many of my orthodontic colleagues did, what could be done with Invisalign. Lee directly said, I'd like to show you some things I've been doing before a nathos meeting, as I recall. And I was so impressed with what I saw, knowing that Lee speaks the truth. Because I'm always thinking, now, wait a minute, are you really telling me the truth? Um, I'm not sure about that unless I know you personally. Lee, what do you have for us this time around?
All right. Thank you guys for having me. I'm thrilled to be here to talk about clear aligners and pediatric dentistry. I love sharing this information with my colleagues because it's what really gets me excited about going to work every day still. I've been in practice 28 years, and this is what fuels me going back to work every day, and I think can fuel me for several more years. Uh, if you've been in practice for a while, sometimes the grind of doing the same thing over and over kind of wears you out. But clear aligners has really sparked that passion and keeps it going. So we're going to talk about kind of how you can get that in your office, and if you want to incorporate clear aligners, kind of a path to take to make that happen. So some of you may know, some of you don't know, I am in Kentucky, coming to you live from the hills of Appalachia. But Kentucky is a really wide state. And at the other end of the object you see here on the screen, which is a fort, which is in the middle of nowhere. Why would there be a fort in Kentucky in the middle of nowhere that is active? How many of you may know where this fort is in Kentucky or what the name of it is? Any takers? Fort Knox. So that's part of Kentucky. And why is that significant? Well, gold. How much is there? Who knows? Because since the 1970s, since we went off the gold standard, who knows how much gold is left sitting in that fort in the middle of nowhere? But why does that apply to pediatric dentistry? If you're a pediatric dentist running your own practice, you are sitting on your little own gold mine. You have an orthodontic gold mine built in already. And what we want to talk about today is how innovations in technology, specifically digital, has allowed us to mine this gold a little more easy and a little more efficiently and apply it to our practice. So let's do a quick math assignment real quick. I want you to think about how many orthodontic referrals you send a week. Just estimate it real quick. Multiply that by 52 for 52 weeks, and then multiply that by $6,000. Whatever your number is, that's pretty much the size of the gold mine you're sitting on right now. And it's up to you to decide if you want to skim any of that gold mine, dive into it, or just go for the whole thing. Because we have this base sitting in our office that we can really access. I guess there's a reason why they say orthodontists love to be friends with pediatric dentists. I'm not sure how accurate this is, but I heard that one orthodontist, if they will get 3 pediatric dentists referring to them, that takes care of their career. So maybe you want to keep some of that for yourself now these days. So let's kind of look at that a little bit, because I think that orthodontics and pediatric dentistry is like peanut butter and jelly. We go together hand in hand because, one, you don't need referrals for orthodontics because they're sitting in your chair when you see them every day. And what do we do with these? Because we, as pediatric dentists, are supposed to be the experts in dental alveolar growth and development. And as the experts, I think we should also be the ones that choose to take care of the issues that we see, because we see it every day, all day long. Now, I really appreciate Fireside having us here, and I want to let everybody know up front, not only am I just speaking for Fireside today, I've been a member since November with Fireside, and what I like about them is that the whole premise is to distinguish private practices from the DSO corporate model, and I think clear aligners is a way that you can do that. DSOs and corporate are not going to allow the pediatric dentist to do the orthodontics. Because they, as Gerry said with the group he's with, they also own the orthodontist, and they want the pediatric dentist to keep referring to the orthodontist. So if you're in that world, you're not going to be allowed to do these things. I have conversations fairly often with people like, well, I would really like to get into doing this, but they work for corporate or they work for a DSO, and they won't even allow them to buy a scanner because they don't want them dabbling in it or even looking at it, because they want it all referred to the orthodontist. So this is a great way, I think, for us to separate ourselves as individual private practices. What do we offer? What can we offer that the corporate can't? And patients, especially parents, love being able to do everything in-house in one place. I don't know how many times I hear the parents say, "You mean we can do that here and don't have to go elsewhere?" I'm like, absolutely. And they're like, yay. Because once they have established trust with you, once the kids are comfortable with you, the parents want to keep them with you for everything if possible. Because we want to be able to provide comprehensive pediatric dental care. You know, corporate does not always allow that. Corporate is a lot of time known as a, drill and fill meal. And if you're in private practice, I think that's the opposite of what we're looking for most of the time. So we can provide comprehensive care. And when we look at comprehensive care, what our academy says is when it comes to managing malocclusion as part of our responsibility, it says that managing these developing problems is a part of the comprehensive oral health care for any child. And if we dig farther on what it says for best practices, it says it's an essential part of comprehensive care, that it's essential that we manage these malocclusions for children. It also says it's an integral component of care for all pediatric patients. Why not do that with our own patients in-house so we can stay more of a holistic, keep everything together in the one place? And then the other thing it says, it's our responsibility to at least recognize, diagnosis, and manage, or we can refer if we don't want to do it or don't feel comfortable with the case. But it's our responsibility to be on top of this malocclusion going on. So whether you treat it, or at least we want to be aware of the problem, we want to be aware of the ways to correct that. So these are some reasons why you may want to think about incorporating clear aligners into your practice. And for me, practice identity is a huge one, which goes back to how do we separate ourselves from the corporate DSO model? How do we stand out by being different? One, clear aligners makes us look modern. Parents want to know that they're going to a place that's got modern dentistry going on, not usually pulling out old amalgams, not using impressions anymore. It blows parents' minds so many times when they realize, you mean you don't have to do an impression? Nope, we just do a scan. And that picture I'm showing you is all you need. Using advanced technology. Let's be honest, as pediatric dentists, there's not a lot of advancements that's hit our realm very often. But digital dentistry, if we incorporate it with our orthodontics through clear aligners, can really change the game to what we're doing. I like to show the parents sometimes a model of the Invisalign. When I'm talking clear aligners, I'll go ahead and say Invisalign is the product I use. There's many out there you can choose, but Invisalign is what I use. So if you hear me saying that, those words are interchangeable. But I'll show them that and I say, well, Invisalign is like an iPhone 15, and braces is like that phone sitting on the desk there. They both work, but one is a lot more nicer than the other. And you'll ask the kid, would you rather have an iPhone 15 or that phone?
Sounds like you think I'm ready for the glue factory.
Well, you're getting there.
I'm getting to the glue factory?
Oh, you're getting with the program.
Yeah.
With this AI stuff, you're coming along.
Well, I'm glad to know that. I feel such a sense of relief.
Now we're not going to ship you off with the horses yet.
One of the things that should time allow, I think most of you know I'm dual trained in pediatric dentistry and orthodontics. And when Lee's talking about the responsibilities you have as a pediatric dentist to the family, to the parents and the child, certainly there are cases that you won't want to treat. And should time allow, I can explain what those are. So it's sort of like extractions. Pediatric dentists take out teeth, but there are certain situations where you think, no, That's not in the child's best interest. It's not in my best interest, and I don't want to stay awake at night. It's like it's same with endo perio oral path.
You know, the other thing with our practice identity, one thing with clear aligners, you get an individualized patient experience. And that's one thing I like to tell parents is that here, what we're going to do is we're going to come up with a plan. And this is only going to affect your kid. Your kid is going to be the only person in the world that this specific product will work on this way. And so parents are looking for that kind of experience, not to feel like they're just getting the same thing that everybody's getting. So clear aligners can help transform the identity of your practice in your community. So again, being in Kentucky, which I'm referring again, we're kind of big on horses. And when you have a 1,200-pound animal, how do you control this thing? Well, there's this bridle and bit, a little piece of leather and metal that helps you control this. And the reason I show this is our practices can be very stressful. Go ahead and raise your hand in the chat if you think running a pediatric dental office is stressful. Because from what we see a lot and what we hear at meetings and what we hear on chat rooms and all that is it can be a very stressful job. And it is up to you to put the bridle on your practice to control that stress. And I will again say clear aligners is a way you can help control your stress. Because what I know with our practice is you don't control your practice will control you. And you got to choose what you want to do, what stressful things you want to do, what stressful things you want to eliminate, and what you want to replace them with. So you can control your stress by choosing what you do. And what we know is there through research or some studies, the most stressful procedure in all of dentistry is giving local anesthesia to a young apprehensive child. And that's what we do every day. We roll in it. We roll in stress all day long. And we even take pride in being good at it. I know I can do it. I can give a kid an injection and they not cry, but still in the moment I'm doing it. That's a stressor that's going on inside of us. And sometimes when you've been around for a long time, you decide, hey, I would like to decrease the stressors in my practice. Now, there's other studies that show across all of dental specialties, pediatric dentistry, oral surgery, and endo are the most stressful, and the least stressful specialty is orthodontics. So what you may choose to do at some point, which I have chosen to do, is replace some of the more stressful things with orthodontics because it's the least stressful thing you can do in dentistry. And as we all know, for our own health and well-being, if we can decrease our stress, life is better. Our longevity is going to be better. We're happier when we go home to our family and kids if we're not stressed out. So digital dentistry, as we kind of call it with clear aligners, is a way to help control your stress. Even among the staff, my staff would rather do clear aligner procedures than any other procedures we do all day long. And it's for the same reason. It's less stressful. Even for parents, it's less stressful for the parents. And then the other reason you might want to consider adding clear aligners to your practice is it's the ability to change the lives of a kid. When we transform a smile, we're not just changing the way their teeth look. We can actually change the outcome of that kid's life. And there was a study done called "What is Beautiful is Good," and Dr. Samson and John Taylor kind of put me onto this, and it is so true. What it shows is people who look good are deemed to be more socially desirable to hang out with. They're deemed to be a person that should have a higher occupational status. They're more likely to be married. They're assumed to be more happy in life and in profession. Total happiness of life, just because they look good, is the perception others have. And there's a greater likelihood of marriage in what's perceived to look good. So when we have a kid who doesn't have a smile that is perceived as looking good, there's a stigmatism that people bring up sometimes that's not verbalized, but an assumption is made that that kid is not as smart, that kid is not as happy, that kid is not as desirable to be around. And when they're young, kids start forming their peers when they're young. So we can change the life of a kid by just making things look better. And we can give them an advantage in life, I do believe. And the other thing about this is parents want to give their kids an advantage. No parent is excited about bringing their kid to the dentist to have a cavity fixed. There's always some parental guilt attached to a kid or to a parent that has a kid with cavities, because the parent either A, they feel guilty because they let it happen, they're mad because they're having to spend money to fix something that they should have prevented. And so there's already some tension there between the parent and you and the staff because of the parental guilt. Whereas when it comes to providing orthodontics, they're like coming and like, help my child. They're more likely to be excited about paying you. Nobody's excited about paying you, but I guarantee you parents are happier to pay for straightening their kids' teeth than they are for a couple of MODOs or some pulps and crowns. And there's just a better relationship with the parents and these patients also. So that's another way we can decrease our stress, is by having a percentage of these ortho cases, because parents want to give their kids an advantage. We all do. We want to do whatever we can to make our kids' life as best as we can help them. So what do I mean? I want to give you a few examples real quick of some of these kids. So this is Ian. He's going into middle school and kids are calling him SpongeBob, and he is acting out in class. He has turned into the class clown. He's accepted his role because of the way his teeth look. Gets to sit beside the teacher's desk a lot because he's acting out. But with some clear aligners, we can change that. And what the report was here is that he went from being a class clown to more of somebody that the people in the class wanted to follow, just because we changed his teeth. So when we change smiles, we're not just changing teeth, we can change the trajectory of a kid's life. Here's Austin going into high school. And I had never met Austin before. His mom heard we were doing Invisalign, so she calls and says, I need you to do this. He needs braces. He refuses braces. I'm thinking, why does he need braces? And then you get behind his lips. Here's what he looks like. Austin's also about 320 pounds going into high school. Not an ideal situation for a young boy going into high school. And he's refused braces because he thinks that'll just put him over the edge on issues going along and issues. So with Austin, we used Invisalign, straightened up his teeth. He went from coming into the office, not looking anybody in the eye, not having conversation, to being actually really bubbly and not having a problem looking you in the eye and talking all the time. So these are the kind of things we can do to change our patients' perspectives on life. Danica here is one of my favorite. Another one going into middle school, and she has an overjet of about 12 millimeters and refuses to smile. And the problem is with these kids now is they're all doing this. They're holding their phone up and taking the selfies about 12 inches from their face. So they're scrutinizing every little detail, when we can look at things and think, well, it's not that bad. But in the kid's mind, it is. So with Danica, we did a phase 1 clear aligners on her, and we went from here to here. Now, looking at this side view, which kid do you think looks smarter? We have preconceived notions in our mind, don't we? Even though we don't verbalize them, and we want to think, well, I would never treat a kid different. We do. But that's just the change with phase 1 clear aligners. The thing I loved about Danica, the story I love to tell, is near the end of her treatment, I hear this crying going on out in the lobby, and her mom was crying with one of my assistants, and she was like, thank you so much. I have never seen my daughter smile. She said she's gone her entire life without smiling and refused to take pictures with her mouth open because of her teeth. And now she does. So, I mean, those are the kind of things we can do. You know, here's another in Hayden, going into late middle school, has this peg lateral. No girl wants to have that smile. So with clear aligners and then some bonding on that peg lateral, we go from there to there. She's thrilled. With clear aligners, you can put in a Pontic in that where that peg lateral is. So she went almost no time without any tooth there while we're doing her treatment. We scheduled like 2 months during the summer to kind of extrude that tooth where she didn't have a tooth and had a crown put on it before school started, or bonding, not a crown. But these are the kind of things you can do to change the lives of your patients. So you can see from there to there in middle school, that makes that girl happy. What do you do when you see this 8-year-old come in with this bite? What is going to be the long-term complications or problems that arise if we don't treat this patient? Those lower incisors are going to keep flaring out. You're going to have stripping of the gingiva. You have periodontal problems. You're going to have wear on those upper incisors. That crossbite may still tend to shift to the left, influencing growth to go asymmetrical. So with, again, mixed dentition only, clear aligners, we can go from here to here. Look how the gingiva changed on those lower incisors by getting her out of crossbite. And again, that posterior crossbite was corrected with clear aligners only, no expanders, no other utility problems or RPEs or nothing like that, just clear aligners only. She did have a frenectomy. And this patient ended up not even needing phase 2 treatment. This is another one of my favorites on why I like to do this. She is one of my top 2 or 3 patients of all time. Lakin's mom come to me because she has really bad ulcerative colitis, and she'd been to an orthodontist and said she had to have headgear to treat her. And mom said, we're going to have a bowel resection done. That is just too much all going on at the same time. So by the time we straightened her teeth, she went to the hospital, had a bowel resection, had the colostomy bag, had the colostomy bag reversed back to normal, and all that was done by the time we finished her Invisalign with Invisalign Teen, and no headgear, no metal, and she just ended up being one of the best patients of all time. Great kid. Invisalign only. Now, this past fall, she was elected Miss Pike County Bowl Queen for the schools in her county. And here's what I like what mom put. She said, a lot of people can do dentistry, but what you guys do as a ministry, disguised as dentistry, you just don't make smiles. You invest in these kids and their families and give them confidence, encouragement to smile. You all make a lasting difference in the lives of the patients and their families. Now, these are the kind of things that make you love going to the office. When we can change a kid, not only a kid, the entire family, because we have the ability to do this. So the thing all of these cases had combined was that we're all treated with clear aligners only, whether it was mixed dentition or a teen phase, they were all clear aligners only. And so that is what I just love about doing it in my pediatric dental practice. Any questions so far? Nope. I will roll on. So what I want to do is not just tell you why you may want to think about doing clear aligners in your practice, but also what are 3 things you can do to kind of get the ball rolling to start to incorporate these into your practice? Because we all know that pediatric dental offices are a different bird. It's usually a high-paced day, and we want to make sure we don't upset the flow of our days because we're all in our routines. So I think there's 3 things you can do if you want to incorporate clear aligners into your practice. Number 1 is you got to prepare. 2 is you got to anticipate. And 3 is be ready to initiate. So those are the 3 things that we can do to begin to efficiently and profitably incorporate clear aligners into our practices. So preparation. 1, you got to have confidence in what you're doing. And that's probably one of the biggest things I see about doctors who are like, well, I want to do clear aligners, but I'm just not sure. And what is it you need to be confident in? One, you need to be confident in your diagnosis. And quite honestly, what I find is everybody is pretty good in that area between what we learned in dental school, what we learned in our residencies, what we've learned through being in practice is we can diagnose the problem really, really well. It's not, we don't usually have confidence that's there. Our confidence is usually, how are we going to fix it? What are our options? So what you need to do is figure out what system you want to use and how you're going to fix these. What are going to be your treatment options? Is it going to be a mixed dentition case? It's going to be a phase 1 and a phase 2. Is it going to be a case I can just wait until all the permanent teeth are in and just do a comprehensive case? Is this a case that's going to need some expansion? We need to kind of know what our options are and what tools we have available to fix these problems that we see, because it's not the diagnosis is the problem. It's the, what are we going to use to fix the problems is what we need confidence in. The second thing I see is staff confidence. And here's where we got to be careful, is what we're guilty as of dentists all the time. We go to a class, we go to a seminar, we hear something, we're excited about it, and we're ready to just roll, and we get back to the office and we tell the staff, all right, this is new and this is what we're going to start doing. But we've been thinking about this for a while. We've got to hear somebody talk about it and tell us how great it is for a while, and then we drop it on our staff and expect them to accept it and roll with that minute. We got to give them some time to think about it and let that cook in their mind too. So one we got to do is educate and train. So we got to spend some time telling the staff how this will benefit our office, how it will be less stressful to our office, how it will be better for our patients, and then train them in doing the things that we need to do to incorporate it into our daily workflow. Because if we don't train them and just say, figure it out, they're going to resent us for trying to do this. And there's a couple of specific places we need to spend time doing this. Your admin staff, your front desk, they need to know how to bill for orthodontics. They need to know how to deal with the orthodontic insurance. They need to know how to develop a payment plan option for those patients, so they're not having to make that up on the fly. It needs to be just memory, like, all right, doc says we're ready to start clear aligners on this patient, and the staff up front needs to know, here's the options for payments, and have that ready to present to the parent. It can't be making it up on the fly, or they will not like you very long and they will make your life miserable.
Hey,
The
Dr.
other-
Boyd. Oh,
Yeah,
sorry.
go ahead.
We had one question from Dr. Reza. What were the rough time frames on the cases that you just showed?
The mixed dentition cases, if there's not an AP discrepancy, if it's just crowding, you can usually figure around 8 to 9 months. If it's a phase 1 that has a AP discrepancy that you want to deal with, like a class 2, usually more like 15 months. So in phase 1, I usually tell everybody about 12 months if there's no discrepancy AP wise, and we usually get done quicker. And if it's an AP discrepancy, I'll tell them 18 months, but we usually get done a little bit quicker, usually around 15. In teens, now it depends how complicated it is. You can cherry pick the easy ones that I would recommend you start with that just take 8 or 9 months. And then as you get into it and want to do the more difficult cases, you can do cases that take 2 to 3 years. Just depends on how deep you want to dive into that ortho mind in your practice. But I would highly recommend starting off with the easier ones for sure. Avoid the AP discrepancies to start with, and that's a good learning spot or a jumping off spot in your office.
Yeah, that's a good segue, as people say, into cases you probably don't want to treat. Certainly general dentists can treat some pediatric dental patients, but they need to know their limits. Same thing for a pediatric dentist or a non-orthodontist doing orthodontics. I mean, I think the same thing for orthodontists. They should know their limits too. Most of my colleagues in orthodontics are really not interested in treating children because they're not trained to manage the child's behavior, but they also have to manage the parent's behavior. That is not part of, I'm going to easily say 99% of orthodontic programs. It's teenagers and adults. So, Reza, the comment I would make is when you look in somebody's mouth as a pediatric dentist, and you see, man, this is a horror show. This kid's got a time bomb going here. They have all kinds of problems restoratively and in their hygiene and their behavior and their parents' lack of taking on the responsibility that they should be taking. There's a lot to do. In an orthodontic case, you look at it the same way. If they have some wicked malocclusion with an asymmetry and an open bite, an asymmetry, and I mean class 2 on one side, class 1 or class 3 on the other, crowding, what many of you know is called a complex open bite, which is a posterior open bite. When you think, woo, I haven't seen much, this looks rough. I don't think you want to treat that. Maybe at some point you will. But to start with, as Lee just said, take the cases that are real straightforward and you're going to and ease into this. Some of you will find that that's what you want to stick with in your orthodontic, whether it's Invisalign or not, practice. And some of you will want to start pushing it a little bit further, as Lee has.
Yeah, I agree. Start with the easy cases. Make your life easier. Don't try to learn on the difficult ones, or it'll just make you get frustrated and quit. I mean, I can think of so many times throughout my career, people I went to school with or others that say, well, yeah, I tried ortho and I just quit. It was difficult. I couldn't make money off of it, whatever. They would get in over their head too quick. And start with the easy cases for sure. As we continue on this confidence, your clinical staff, talked about having your front office staff prepared, but you got to prepare your back office. You can't, again, just have a patient show up and say, all right, go do records on that kid if you haven't trained them on how to do records, how to properly do that. And you want to spend some time preparing your staff of why this is going to be better for them, for everybody, for the stress level in the office, but also preparing them on what they will be doing so they can be efficient at it and that you've properly trained them. And then the other thing for preparation is you got to have the proper equipment. Now, when it comes to orthodontics and clear aligners, one, we need a pan and ceph machine. Most everybody has a pantograph in their office. Some have the capability of doing a ceph, some not. It's a whole nother can of worms we'll get into whether you should have a ceph or not. I think, yes, you should do a ceph on everybody you're doing ortho on. Not the entire community believes that way, so I'm just going to leave that there, but I think you should have a pan and a ceph. Second thing you need is a scanner, and this is where a lot of people balk a little bit on doing clear aligners, especially when it comes to the brand that I like, because their scanners are a little more and they will only let you use their scanners for their product. But it's an investment. I mean, you will not do clear aligners without a scanner. Whichever brand you go with, if you try to do impressions and send it to them, you will just get frustrated and you will find it's not easy to work into the workflow of the practice and you'll just not do it. So scanners make everything so much easier. It's so quick. The kids tolerate it so well. No impressions. And it just makes your communication with the company's lab that you're using really quick and easy. So I would highly suggest you invest in a scanner if you want to add clear aligners to your office. Just think of it as a necessary evil, but I would highly do it. Now, like I said, I use Invisalign, and the top level scanner is like $47,000, and people are like, how much would you pay to make, a few $100,000 each year? Is it worth it? Yeah. If you're not sure, will you get into it? I understand, but there's different levels. You can start with the $15,000 scanner, decide whether you like it, and if you get into it, then trade it in for the Cadillac model. So there's options on those. So don't let that scare you away. Plus, I could get over almost a whole nother lecture on how you can use scanners for other uses in pediatric dentistry now. There's so many uses, just from appliances to go to labs. I use it for parent education all the time. Um, Lab work. There's a lot of uses. And the other thing is composite. Really, that's about the only other thing we need, and that's to place attachments, and we all have that sitting around in our offices. So, to be prepared, you need to have your doctor confidence in diagnosis and treatment options there. You need to be confident in what you're doing. You need to have your staff confident in what they're doing. And you need to have the equipment. If you don't have those in place, you will not begin doing clear aligners or any orthodontics, because you see a case and you'll think, and the patient needs it, but I don't have everything ready, so we're going to refer it. We'll wait till we get everything, and then you never get everything ready. So you just keep referring. So the second thing I said after preparation was anticipation, being ready for things to come in to fix, being ready to address patients' orthodontic malocclusion problems. And workflow in pediatric dentistry is, because our schedules are so hectic, if we don't have a workflow set around, we will never anticipate properly to incorporate this into our practice. So one thing I recommend you do is every exam should include an orthodontic exam. Even when you're doing the lap exams at 12, 18 months old, be doing an orthodontic exam, making notes in the chart, but tell the parent what you see that may be a problem when they come down the road as they get older. And if you start pointing these out when that kid's 18, 24 months old, by the time they're 6, 7 years old, the parent understands what's going on. And when you predicted that was going to happen and it happens, they have the trust in what you say. So they have the confidence in whatever you say to do, they'll usually go with. So start incorporating an orthodontic exam, every exam, no matter how old, but more importantly, share with the parent what's going on. Then making sure you're documenting the patient's needs in the future and what you anticipate to happen in the future in your chart. So maybe you're thinking, hey, I think there's going to be some crowding in these canines. In 6 months, I want to palpate for these canines and make sure it's noted in your chart. Be watching what your patient needs are so you're not getting lost on any of these things. And then be asking yourself, when do I need to start treatment on this patient? So will this patient benefit from early treatment or phase 1 treatment? Will this patient be okay to wait until all the permanent teeth are in to start treatment? What's going to happen in the wrong direction if we wait? And is it okay if we wait because it's not going to get any worse? Be asking yourself those things so you can be thinking about when you want to start treatment on that patient. And the reason you want to do that is so you can have your schedule set up, because our offices are crazy. And we know if we throw a wrench into the schedule in the middle of our day, our staff will want to wring our necks. So what I do is make those notes. And when I think that patient's going to be ready for treatment at their next recall, it's a different color on the schedule. That patient shows up bright teal on our schedule that day. So in the morning, everybody knows Dr. Boyd's going to want to do ortho records on this patient today at their recall. I've been watching it for, years usually. I know it's time to start treatment. The parents heard me talk about it. So that day on the schedule, they're going to know to go ahead and be ready to take records for me that day. So we want to incorporate this into our daily workflow so everybody's happy about it. So let's say you have the patient in your chair. Now is the appropriate time to start treatment. This kid is ready. You've been preparing the parent. You've been watching it. And today's the day. You're like, all right, we really need to start this now. Now what? What's our next steps? So what you want to do is you want to scan the patient. And what is important about this scan? Well, the scan, for one, it'll be a part of your records instead of having to do models like we used to do back in the 1900s. Now it's all digital. But more importantly, it's to educate the parents. And with the parents, you can pull up that scan and then show them a simulation of where we want to be, and that makes complete sense to them. So like this patient here, they were ready to start treatment. I show them the scan. I take a scan. The picture on the left shows them what they look like now. The picture on the right shows them where we want to get to and what we can do with clear aligners. And when I show them these pictures, they understand. A lot of times like that overjet, the parent really didn't even notice it until you turn and show them from the side what it looks like. And they're like, oh, I didn't really realize it was like that. But these scans are a great tool to educate the parents. It saves you from trying to explain a lot of things that they're not getting, because we want to talk about it in doctor terms, and the parents need to hear it in layman terms, and the visual is what they need. That's what bridges the gap. So that scan can just work wonders on educating the parents. And then once you show them those, I'll tell them, all right, the next thing we want to do is develop a plan individualized for your child. And we call that records. And that's where we'll take some photos and x-rays so I can develop a plan for your child. So at that point, right there, when you're showing them the scan of where they're at and where you want to get to, ask, would you like to do records now? Huge question. Would you like to do records now? Now, you've most likely already got the Panorex. Your staff already has a scan, which is basically your models. All they need to do is take their iPhone and take 3 photos and a Ceph x-ray, and that's all that's left to do for records. So it takes 5 minutes. So it's not killing your schedule. But tell the parent, hey, since you're already here, would you like to go ahead and do those records now? We can save you a trip. And they will usually say yes 99% of the time. And then once you take those records, say yes, you get the records, schedule them for a treatment plan appointment. Typically, you would like to keep that within about a week if possible. So this is where, as you're getting your workflows down, you want to keep some time in your schedule just for treatment plan appointments so you can present these. I always make a point at these appointments to tell them that whoever's going to make the decision on starting treatment needs to be whether it's mom or dad. Almost always mom. If it's a dad, we know we're probably wasting our time. We really want mom there because she makes the decision. So we try to tell them, hey, if both parents can come, that's the best scenario for sure. But definitely we want to try to do it where mom comes to that appointment. So if we can schedule them for a week later to come back and go over everything. Now this is for, I think, pediatric dentistry, the biggest linchpin in starting orthodontics is because we get stuck on the thing. We need to see them, show the parent that scan, and then tell them exactly what we're going to do that day. Well, we don't have to do that, and our practice schedule does not allow that to happen because you got 16 recalls waiting to be checked probably. So give yourself the time to properly develop and do a treatment plan to present to the parent. So schedule that appointment, and that gives you about a week to take those records, sit down and go over them all to diagnose and make a plan that's going to be appropriate and individualized for that child. And that's the key for me, I think, to incorporate into your practice, because you will hear a lot of clear aligner gurus say, oh, you want to tell them you're going to do this right now and get that down payment right now, and then figure it out. That's not a good way to treat our patients, I don't think. I don't think we want to get their money and then figure out what we're going to do. Or at least I am not comfortable doing that way. And you're not cost them any extra appointments, because if you was going to refer them, you got to go to another appointment for the same thing anyway. So you're still saving them a trip.
Yeah, I agree with what you're saying wholeheartedly. In orthodontics, the standard of care, in large part, has changed to same-day case starts, and I personally am very uncomfortable with that. I question whether there's some liability to doing a same-day orthodontic case start when you haven't made a plan. But I have been woefully, well, not woefully, but directly contacted by the American Association of Orthodontists risk management people and said, no, they don't see a liability in same day case starts. So you have the whole comment there. The other comment that I'll make is about having a Ceph. And I think it's fairly common knowledge that many of you, well, all of you see orthodontic patients from orthodontist's office, from university trained, perhaps board certified orthodontists. And I think a lot of you, the vast majority, are aware that frequently the cephalometric film is not being traced. If you talk to the legal people involved in this, specifically, I'll mention a close friend of mine, Larry Gerald, who is an orthodontist and a lawyer. When he speaks on this topic, his comment is to the orthodontists: if you are treating an orthodontic case and you don't have a diagnosed and traced Ceph, Larry said, I don't care if there's 3 lines on it. If that's all you make is a tweed triangle and that's all you have, okay. But if you haven't done anything on that ceph, you have a real problem. So it's similar to if you make a bite wing on a patient, you have to make a comment. So I'm going to underscore what Lee said earlier, that I don't think it's appropriate at all to be treating orthodontic cases without a complete diagnosis, which would include a cephalometric film. Lee, back to you and why you are in Kentucky and I'm not.
I don't know why I'm in Kentucky and you're not. I'm cooler, I guess. No, I don't know. But uh, but allow yourself the grace to develop a proper treatment plan for that child. That's where so many pediatric dentists get frustrated, like think I can't do this. You can, but if you try to do it in the spur of the moment in a busy day schedule when you're seeing 45 patients, you're not. So schedule that time so you can develop a proper case. And this is where you're going to do the work when it comes to clear aligners. Quite honestly, the bulk of the work is there when the patient's not in the chair and you're going over your records, deciding what the problem is, deciding how you're going to fix it, developing your software for whatever system you're using for your clear aligners. You know, for Invisalign, it's called a ClinCheck. You're going to spend some time during that week developing your ClinCheck or whatever your company's software is called to make sure you have an accurate plan that's actually going to work. You don't want to just take a scan, send it to some company, and then take what they send you, because then you're not being a doctor anymore. Then you're just letting someone else do the doctor work. I think it's our responsibility to actually work up a correct diagnosis and treatment plan and make sure it's something that we believe is going to work for sure. So this is where we're doing most of our work. And then when it comes to actually time starting the treatment in the office time, that's mostly very staff heavy on time. And that's where clear aligners is very profitable for a pediatric dentist, because your staff can be doing that while you can be doing other things. And it allows you to be much more profitable. You don't have to see your clear aligner patients as often as you do braces patients, which opens up more chair time, which we know as pediatric dentists, chair time is where all the profits are made. So this is why clear aligners can work out so well in a practice, because the bulk of our time is not taking up patient chair time. Ours is doing this during lunch, at the end of the day, in between patients, and working this up. And then, so you've spent that week developing a plan, coming up with your ClinCheck, and you have the parent come back. You're going to present this treatment to the parent, and then you also want to present a financial plan. So I am showing them, models of Invisalign, showing them what the ClinCheck looks like on the computer, telling them what their responsibilities are, going over it with the kid, getting the kid on board, and then I leave the room for my financial coordinator to come in. Here's what I hear often, especially from Invisalign reps, is that doctors kill their cases when they do the financial presentation also, because apparently that most parents, when they hear the doctor talking about spending these large amounts of money, it's the rich doctor and it's no big deal to them. And so if someone besides the doctor is presenting finances, it tends to make case acceptance go up quite higher. So I would highly recommend that you don't discuss the money. If the parents even ask me how much it is, I will say, I don't know. I'm going to let Sharon come in here and go over all that with you. She's got your insurance broke down and all that. I know how much it is, but I'm not going to get into it with them. I say, I just know what to fix, and she's going to go over all that with you and all the options on how you can pay for it. So I would highly recommend that.
That's an interesting thing that you mentioned, Lee, because if you look at the studies that have been done on what are called lay case presentations, meaning not presented by the doctor, they actually, in fact, if you look at Medical Economics magazine, what Lee said is true. They are, in fact, more successful. But you have to have somebody who is skilled at this on board. Lee?
Yes. And that's why the line reps, actually, I don't know, I've had several come to my office just to see how we do a treatment plan, because, and apparently that seems to be the linchpin in a lot of it, is that I don't talk about finances. Then you're ready to begin treatment. Once they pay the down, I leave the room, financial coordinator goes in there. Once they give her a down payment, she tells us, and then I order the clear aligners. We get them in the mail. We start the treatment. I don't have a whole lot of involvement in that. When they come in, the staff is putting on attachments, check on your state's laws and regulations. But if expanded duty assistants are allowed to do things in your state, I would highly recommend you allow them to do all they can, because my staff is putting on attachments. They're teaching the kids how to take them in and out and going over hygiene and stuff. And I am just a big cheerleader when it comes to Invisalign on my patients. I'm coming over. Hey, how's it feel? Usually say weird. It's the number one answer. I remind them, hey, what's the magic number? Because I tell them 22 hours is the magic number. And I ask them that a bazillion times to where they get sick of me asking. And I high five them. And that's about all of my involvement is. So, I mean, and that's what I like. And that's why it's efficient to do this in your practice.
Hey, Dr. Boyd, we got a question from Dr. Green. How do you incorporate the treatment plan appointment? Do you build in specific times in your schedule? And if so, how long? And then does the kid need to come to that appointment?
Great question, Dr. Green. Yes and yes. We try to block time for treatment plan presentations, and we like to give those prime times 4:30 or 8:30, because I started at 8:30, because a lot of parents like to come first thing in the morning and go back to school. So those two we have block times for, usually 30 to 45 minutes on that time. I'm not in there probably, I'm in there about 20 minutes of the time. And yes, I do want the kid there, because I'm going over the instructions with the parents and the kid, and I make the kid sign a contract between me and the parents that they'll do what they promise that they need to do to make the treatment happen. So yes, I want the kid there and block schedule for it, because if you're booked out 4 or 5, 6 weeks in advance, how do you get somebody back in a week? You got to have those times blocked out. That's where you got to work it into your workflow to make it work in your practice. Great question.
Yeah, I'll jump in on a comment on this. I have been to Lee's office. I drove there from Atlanta, and I have never been more impressed with the way an office runs and the esprit de corps. These people that are working with Lee, they're just having a blast. And trust me, it's not because they weren't putting this on just because I showed up. You could see it was really genuine. And I want to underscore what Lee said about your State Dental Practice Act. You really do need to know what it is. It's when I saw what Lee's assistants were doing, I will tell you that I think my eyeballs started moving out on the stalks, because you couldn't do that in Georgia. They're using high speeds for the composite and all of this as completely legal for expanded duties in Kentucky. And I was more than slightly impressed watching what the Invisalign. You have 2 Invisalign assistants, isn't that right, Lee, or am I wrong?
Yeah, I have 2 that are the attachment ladies. Yeah.
They were really impressive. They were smooth at what they were doing. So part of the reason I'm explaining this to you is I think that if you start getting more and more interested in this, I will mention this to you. Lee is the director of Clearly Nathos. It's the clear aligner section of Nathos. But Lee also has his own situation where you'll need to contact him about this directly. But he does have programs where dentists come to his office and observe, like I did, and see exactly what's going on in real time. It is more than worth your time to do this. And the business manager in Lee's office is nothing short of gifted. That gifted woman also happens to be his wife. But it is impressive and well worth your consideration. Lee, back to you.
Yes, I have the hottest office manager in the country. Absolutely. But thanks for the plug there, Jerry. The next in-office time is late August after school goes back. If you're interested, hit me up. I'll go on from that. But yeah, beginning treatment, staff heavy. Use your staff, train your staff. So this makes it efficient into your workflow. And this is the staff does the most of the work here. We have a light load when it comes to actually doing the treatment in the office. Then you monitor the treatment. I bring them in after 6 weeks when I give them the aligners, and then typically 8 weeks after that, sometimes 10 weeks. And most appointments when they come back in are really quick, easy appointments. The staff gets them in, checks the attachments, make sure they're on, checks the fit the next aligners. If the next aligners fit, I get a thumbs up, which means I come over there and give them a high five. Want to brag to the parent. That's what I'm doing. I'm cheering. If they're not fitting, then I can get involved. But most of the time, it's, again, just being the cheerleader role. And then when we finish, it's retainers. And, retainers are for life. And we try to make a big deal about that. And there's a lot of different options on retainers and stuff like that. On a side note, that little hand with the 4 like that, I spent about 45 minutes trying to get that on Chat GPT or Grok last night, and I could not come up with it. And who Jerry was talking about a while ago, Jay Eddie, I was on the phone with him earlier. I told him, he sent it to me in 4 minutes. So I can't wait to hear him in November to see what he says to the Nathos people, because we got to get on board with this AI stuff. It's pretty awesome. So that's pretty much how to incorporate it in the office. You want to be prepared, you want to anticipate, and then you want to initiate what's going on. So we've talked a little bit about the benefits of starting clear aligners in your practice, whether it's for stress, whether it's for finances, whether it's for being able to provide comprehensive care, for it to want to be your identity of your practice. And we talked a little bit on how to incorporate clear aligners. So hopefully you all found this valuable and heard some things. If you want to get a hold of me, here's my email address. That's the easiest way to do that. I got a short plug for what me and Jerry's doing next month. We're doing a 1-hour webinar on a specific case. A lot of you have seen information on this, but there is literally only 10 spots left, and then our Zoom thing will be full. So if you're interested in that, we're doing a really crowded case, mixed dentition, no extraction. So if you're interested in that, email me so I can get you a link for that. And this is the case that we're going to be talking about. And what questions does anybody have?
While you're thinking over if you have a question, I think Allison's going to field the questions. I'm going to mention this thing that Lee started off with about the financial attractiveness of bringing something, additional things of value into your business. And one of the things I'd like you to think about or rethink, if you've heard me talk about this before, is the idea of having financial security is the reward that we get for the blood, sweat, tears, and in some cases, massive amount of debt and emotion we've undertaken to become a dentist, whether it's a general dental specialist, a pediatric dentist, an orthodontist, God forbid, a periodontist, or an oral surgeon. I think that sometimes people get embarrassed by talking about money or how much money they're making or how well they're doing. That money is the security for yourself and your family. Allison, do we have any interesting questions that have come up?
Well, we got a thank you from Dr. Bloom, and then Dr. Reza asked general time frame for the new Invisalign expander, and how long are you holding them before continuing phase 1 aligners?
The expander is usually, I'm spending about 2 months doing the expansion, and then I'm holding them about 6 weeks before I go into Invisalign first.
Was there something else, Allison?
That was it.
Well, the Invisalign expansion is in many circles, is very controversial, and it has blown some people away, and I would be one of those blown away. That no one expected with this removable, very stout. What's that thing made out of, Lee? It's
Printed nylon.
Printed nylon. I mean, this is not an Invisalign tray. Many people, Stefan Reinhardt being another one that many of you know I'm close friends with, no one expected skeletal expansion with the Invisalign palatal expander, IPE. Well, what people started seeing were rather substantial diastemas. And again, because I trust Lee Boyd at his word for every possible reason you can imagine. Lee shows cases in clearly nathos at the meetings here in Atlanta where he did do an occlusal x-ray, which I did routinely in my pediatric dental residency. And you would look at that and think, why are we using quad helixes or RPEs or pin tube expanders. You started wondering, why am I doing the X-ray? The suture's always open. Why am I doing that? Well, Lee did some palatal X-rays on some patients that I think the story you tell, Lee, is you didn't expect to see that diastomy either. That was like 4 millimeters. In what period of time was it, Lee?
It was like, I think, 4 weeks. I didn't expect it to happen, and so I didn't give him the standard, hey, you're going to get a space between your front teeth like I would with the RPE, because I really wasn't sure what happened. And she walked in and they said, but she's kind of worried about this space here between her teeth. Perfect. That's exactly what we wanted to happen. Now I tell everybody, if you're interested, if you're going to be at Denver, I'm going to be talking about the palatal expander on Friday around 12:30 at the Academy meeting. So I would love you to come by and say hi, if you're interested in that. So,
Well, you
And
should
then oh, sorry, go ahead, Dr. J.
you should be aware that there's no literature on this. There are no publications that I'm aware of about the Invisalign palatal expander, again IPE, compared to Hyraxes, quad helixes, Porter appliances, pin tube expanders, or a removable expander with an expansion. You call that a jack screw in the middle. There are no studies comparing those. And what one would ask quickly is, long term, with an Invisalign palatal expander, is it as stable? Because we all know that some of these relapse. Well, is it as stable as these other methods where there are, for example, RPEs, where there is a substantial amount of literature? Well, in my way of thinking, again, this is my opinion, Invisalign does not need to prove it's better. They just need to prove it's as good. But that literature is not there. So if you're an evidence-based freak, you're going to be waiting a while for that evidence. Allison, you had something?
Oh, yes, we had another question. Dr. Dean, what cost-effective intraoral scanner do you recommend for clear aligners?
well, it will depend on the system you use. If you use Invisalign, you have to use iTero scanner. They don't give you the option. And they have versions from the $15,000 Prius to the $47,000 Cadillac version. What I personally think is you want one that has the capability of showing a simulation, because that provides so much education to the parents. That's what I would recommend. Now, if you're using another company brand of clear aligners, ask them what they recommend, because you can definitely get some cheaper scanners with some of the other companies. So I don't have experiences with those, so I can't really give you any specific recommendations, but I know that there are options out there. That's my thought on the scanners.
In the orthodontic world, I can tell you that close friends of mine that do a substantial amount of fixed appliance orthodontics, a substantial amount of clear aligners. The comment is pretty much across the board. Yeah, there's other things that are less expensive. Clear Correct being one of them. Angel aligners is another one. But people who have actually tried those things, and I'm not one of them, but I'm very curious what these colleagues and personal friends who I trust, who have done these things, their comment is Invisalign is still, it's the blue plate special. That's the way to go. They have put all of their effort into the ClinCheck. So as you're thinking about this, I'd be careful about buying a scanner myself if I was in that game, that I was going to buy a scanner that shortly I would be unhappy with and end up losing 5, 10, 15, or 20 grand because I didn't buy something of that would give me more variation and more top of the line. So I think it depends on how you look at it. And Lee obviously has his information up here for you. And I know that Lee is happy to answer any questions that you have. Before Allison gives us anything in closing that she'd like to provide, within, let's see, in about 1 minute, everybody that's on the Constant Contact Nathos mailing list, which is just shy of 7,000 people global, will be getting a blitz coming out about the it's called Essentials and Beyond, about clear aligners, Invisalign specifically, that Lee and I will be doing. The last one this year is going to be in December. It's your last chance to do that. And then there is an intermediate advanced Invisalign meeting in January. So if you're on that mailing list, you'll be getting that information probably any second. Allison?
I think that's it. I put in the chat. We are doing another session next week, open to everyone. It is a CME with Dr. Hector Vila from Pediatric Dental Anesthesia Associates, talking about what can go wrong and has gone wrong in pediatric dental sedation. So if you're thinking again about adding a sedation practice or you already have one, he'll be sharing a lot of great insight during that CE. And then Dr. Gerry, you'll be back here with Dr. Larry Gerald talking about ethics and the law as it relates to pediatric dentistry on May 16th. And then as Dr. Boyd mentioned and Dr. Reza pointed out, we will all be in Denver for the annual session at AAPD, and we will be front row for Dr. Boyd's session. Fireside will be there as well. So come by and say hey in person. We would love to meet all of you. But thank you. Oh, go ahead.
I was going to ask, as far as the recordings, because this has been recorded, and I think all of you are aware that Fireside has been quite generous in providing this information as a courtesy to dentistry and not charging anybody for these sessions, these FaceTime Fireside sessions. But they are being recorded. So, Allison, do people have access to those recordings if they are or if they are not Fireside members? What's the policy?
Yeah, so we'll send out this recording, and for Fireside members, obviously all the recordings are available in the app. And at a certain point, we'll probably limit those down just to the recordings to the Fireside members. But for this one, we'll go ahead and send that out in an email.
Wonderful, thank you. Lee, outstanding. Allison, thanks very much. And thanks to all of you for zooming in. Have a dandy weekend.
Thanks.
Thank y'all. Bye-bye.